topic was advanced NAFLD management in diabetes, a practical update. Now, when you ask for a practical update, it is about how you are going to, in practice, how are you going to work? What do you need to do, right? And a lot of advances have been tried, billions and billions of dollars have been poured in, or I would say, sometimes I say they are wasted, okay? I don't know, they are usefully utilized or wastefully utilized. For reasons I'll speak later. But for me, a lot of it is wasted because I'll come to the reason later. Now, why is this topic chosen? Probably it is chosen because of the magnitude of the problem, and there is a very close relationship between diabetes and NAFLD. Whether it's a cause, diabetes is the cause, or sometimes it's the consequence of NAFLD, that is also not very clear. And whether they are fellow travelers. So there are a lot of question marks which have not yet been solved. And then you have this diabetes with NAFLD, the outcome. If you have diabetes and you have NAFLD, you are more likely to have complications of diabetes, that is coronary artery disease, CKD, and NAFLD is believed to be associated with certain manifestations like cirrhosis, hepatocellular carcinoma. So if you have diabetes, NAFLD patients are more likely to develop cirrhosis of liver and hepatocellular carcinoma and liver failure. So that is the problem. It's a vicious cycle. So I thought, since I have been probably called as a hepatologist, the reason might have been that when should a diabetologist refer a patient to a hepatologist or to a specialist or a gastroenterologist for specialist liver intervention. And same thing, I think diabetes with NAFLD, it should be, when should a hepatologist, he should manage it himself, or whether you need the help of a diabetologist, okay? And what are the guidance available for this? This is just to highlight the huge problem, that diabetes is a big problem, and we have, in South Asia, we harbor 1/5 of the world's total population, 1/5, and diabetes is so very common as the figures show here: Nepal, India, Sri Lanka, Bangladesh. So it's a huge problem, and probably, as many of you would love to say, that we are the capital of diabetes. And just like you love to say that you are that India or South Asia, we are the capital of diabetes, I love to say that with the NAFLD pandemic, we are the capital. We are the capital of NAFLD, whether related to diabetes or unrelated to diabetes. They are very closely related. Diabetics with NAFLD in South Asia. Now, this would be, diabetes, we are around roughly 136 millions. I don't know that the number must have increased. This is an old slide. And with diabetes with NAFLD, if 50 to 70% of them have NAFLD, it's around 68 to 102 millions. We don't have real figures for NASH. And so this topic always, I think of this soap. Ye rishta kya kahlata hai? What the relationship? How are they related? We have done a number of studies, including this, that the prevalence of diabetes and pre-diabetes. Then we did the study on NAFLD in subject with type 2 diabetes mellitus and non-diabetic with special reference to insulin resistance and hepatic histological changes. We have now a cohort of not 6,000, the old thing, more than 6,000. And I am actually the chairman of the ICON-D, that is the Indian Consortium for NAFLD. And we have there 7,000 patients. We just published a study with 5,000 odd patients. So we have we have learned a lot of things about NAFLD. And yet, I think we know very little about this disease. So when it comes to the problem that when should you refer a patient, there are a large number of studies done like this study, which has been done in the West, in Brazil, CAN-FIB4 and NAFLD fibrosis score. These are two simple scores which can be done, by all of us without taking recourse to a lot of complicated tests. With a simple test, all of us do. Whether they can help. This is one study This is another study which has been done again to look into this aspect and to how to decide which is the patient of NAFLD. Should all you cannot refer all patients with NAFLD. All patients of NAFLD don't require liver biopsy also. Hardly anyone requires a liver biopsy. So without liver biopsy, without anything, how are you going to decide that, okay, this patient probably required a specialist attention, a hepatologist attention? So a lot of studies have been done. But unfortunately, the net result is, see, now look at this here. You can see the sensitivity is so low in picking up, liver fibrosis. It is quite low. We did a study in India with the available, in our part in Orissa, with the available cutoff for various of the studies, FIP4 and NAFLD fibrosis score. We found they are very, very poor, very bad in identifying patients who have significant fibrosis. And what is the reason? These values have been, these cutoffs have been, adduced. They have been from patients with diabetes at very, very high BMI. Our patients are different. Our patients are not the same NAFLD and diabetes patients as in the West, where you have 35, 40 BMI is very common. We hardly have BMI more than used to have. Nowadays, of course, it is gradually going up, but our BMI levels are very low, as I'll show in my subsequent slides. So a lot of people are struggling to find out different markers where people can predict that, yes, this is a case of fibrosis, and if I don't refer and have a problem, it is both from the patient viewpoint and from the physician viewpoint, from a legal viewpoint also, that why didn't you refer to this patient, why did you refer to this patient so late? But see, this is the conclusion after a lot of tests. Clinical judgment and further testing, including liver biopsy, may still be needed in patients determined not to be at high risk for NASH or advanced fibrosis, using all these models, available models. And now you have, combination. You have something called a fibroscan, like ultrasound machine. You have, a special system where you can even check for fibrosis in the machine. So now you have a combination of this fibroscan plus AST, fibroscan plus FIP4 and all those things. And for this also, they are finding cutoff. But now, see, this is for a specific population. To say that this will work in our population is not practically possible. And hence, currently, I would say that current NAFLD guidelines for risk stratification in diabetic patients have very poor.
But excuse me, your slides are not changing. If you want to change the slides, it's in the first slide only.
Oh, did it change? No,
sir. I have given a message to change the slide. It's still in the second slide.
Yeah, no, the slides are not moving.
No.
RX people, just to look into.
Then only sir have to change the slides. We do not have any access of that.
Okay, I've gone through half of my presentation and right.
And now it is visible, sir. In the 22 number slide is visible. Can continue if you are at the right track, sir.
I think this is better, is it?
Yeah. It is visible.
Okay, we'll do this.
Click on the slides, please. Click on the slides. If you won't move it, please click on the slides on the left-hand side.
And you can continue from here, Professor Shivaram.
Okay. Yeah. Oh, this is where I was actually. Right, I'll do that. So
yeah, you could just click there.
Can you see the slide?
Can you click it on this where you put your now cursor? It will become full screen. Just click there.
Yeah, I have done it. I have clicked already.
Okay, then continue.
Okay. Is this moving?
Yeah, moving now.
Yes.
Okay. So see, this is just as I was telling you, the BMI of Indian NAFLD patients and Western NAFLD patients. On one side, you have all the Western, on the basis of which all those cutoffs are calculated. And on the other side, you have the BMI of Indian patient. It hardly, the average BMI is around 26, 27, but it is much, much higher. That is the reason why they don't work well. So, with this, when we talk of treatment, you all know, I should not go into the newer molecules which are now available for you all in the field of diabetes that you all know. In the field of NAFLD, unfortunately, the only molecule which has got clearance from any agency, national agency, drug clearing agency, is saroglitazar in India. It's not got clearance by FDA or the Europeans because of the simple fact that it has not, for a molecule to have any effect or to be cleared for NASH, it must bring down fibrosis. Till now, saroglitazar has not clearly been shown to check the fibrotic part. So if you look at that, we do not have a single molecule excepting vitamin E as well as pioglitazar. These are two molecules which all the national bodies or the international bodies recommend for use in diabetics or non-diabetics. The big problem is all of these require liver biopsy. Liver biopsy is a must in all these cases if you were to start. As far as the European Association or the American Association, their guidelines say. However, that is not possible. You can't do liver biopsy just to start the molecule. We don't agree with that. And that is why the Indian guidelines have been different. So with the various molecules now being used for treatment of NAFLD, I always say that they are no better than placebo. And actually for diabetologists, the take-home message would be that all patients of diabetes and NAFLD should be managed with the care meticulously, mainly with lifestyle, diet, anti-diabetics, the other molecules you use for your diabetes patients anyway. Plus, there is nothing more hepatology has to offer. Excepting in our meetings, I have always been telling exercise and diet is something most diabetologists don't educate, most of the hepatologists do not educate their patient properly, don't educate them about what their waist should be, what their weight should be. So there are two important messages here which I have been talking about. They are the BMI should be kept below 22 if you are managing NAFLD. If you bring it below 22, almost 100% of the fatty liver will become non-fatty, number one. The second simple thing is for patients, they can measure their height. If their height is, say, 180 centimeters divided by 2, 180 divided by 2, 90 centimeters, their waist should not exceed half of their height. If the weight comes below that, they are less likely, they are unlikely to have fatty liver disease. These are the two simple things which my slides don't show here, which I always tell my hepatologist friend, is something they need to educate their friends about. And when we come to the national, the Indian liver guidelines, these are the tests we generally use actually is for liver stiffness, we use a fibroscan. And if we have a high fibroscan, that is more than 8.2, we think that this patient is likely to have significant fibrosis. So probably fibroscan is not as costly in India as it is abroad. So my recommendation would be that instead of going through all that, you do a simple fibroscan, say once in a year, and if it is more than 8, you better consult a hepatologist. That is better. Next. These are the treatment regarding drugs. I am coming to the end of my talk. These are the drugs. Pharmacotherapy should be considered in patients with liver biopsy proven NASH with or without hepatic fibrosis. NAFLD recommends vitamin E as pharmacotherapy for NASH with or without hepatic fibrosis in non-diabetic adult and pediatric patients. And pioglitazone as pharmacotherapy for NASH with or without hepatic fibrosis in both diabetic and non-diabetic adult patients. This is a 2023, that is the current guideline published few days ago. And NAFLD recommends saroglitazar as pharmacotherapy for NASH with or without hepatic fibrosis in both diabetic and non-diabetic adult patients. This is the last recommendation from NAFLD. In patients whom liver biopsy is not available, NASH-specific therapy, I mentioned, can be found to have, if you use non-invasive markers. And in non-invasive markers, I would suggest that you should use FibroScan. And for pending further evidence, NAFLD suggests not using obeticholic acid. This is very important. This is the only guideline we specifically mentioned that at the moment we should not be using this. And pending further evidence, and this should not be used in NASH. These molecules should not be used in NASH cirrhosis also. So the take-home messages are same. Most important, I think, is are these things for all of you, for the hepatologists, for the diabetologists. Superior doctors prevent disease, mediocre doctors treat the disease before evident, and inferior doctors treat the full-blown disease. If you keep the waist less than half of the height, if you keep the BMI below 22, with whatever dietary manipulations you use, and with other standard therapy, patients will not have fatty liver. Thank you.